Yeah, I can't for the 9:10.
Hello, welcome everybody watching. I'm Alan Tay. I'm your DOPS host for the 8th SJMC Cardiology Grand Rounds. I just want to take you through the housekeeping slide before I pass over to my cardiology colleagues. So next slide, please, Kevin. This is just to remind you, we are having questions and answers at the end of the session using Slido. So can you please, on your mobile phone, go to slido.com and then enter M087, or else scan the QR code with your QR code scanner, not the MMA app, the normal QR code scanner, and it will take you to slido.com and join us at M087. That's the meeting code. All right. So Q&A officially there, and it will be only at the end of the session. Next slide. And our QR code will be displayed at the end of the talk for you to scan with the MMA app, and that will be only at the end of the presentation. Okay, and you can claim your points. For those of you who are registered with DOPS, there are some MCQs which we'll host later. So in case you didn't watch this live, you can go to the bulletin board and watch the video and answer some MCQs to claim points. So that is for the non-live. It's not yet up, but it will be hosted later. I hope you all got the email notifications for this talk. One of the best ways to remain notified of our upcoming meetings is, if you're watching on our YouTube channel, is always subscribe to the channel and hit the notification bell. And do like this video so that all your other colleagues will, you'll spread the video amongst your friends and colleagues by the YouTube algorithm. All right. Okay. I'm going to now exit and pass over to the moderator for the session, who is my senior colleague, friend, and eminent cardiologist, Dr. Kanan.
risk and therefore the prognosis, and the assessment of the significance of coronary lesions. And we will do this by evaluating symptoms.
We have to start again. There was an audio glitch. I cannot remove myself from the stream. Sorry.
Start again.
From the beginning?
Yes. Sorry.
Okay. All right. Start now? Alan? Start now?
Can you just check your sound again, please?
My sound is working.
Testing 1, 2, 3. Let me go through. Testing 1, 2, 3. Is okay now? All right.
Yep.
All yours.
We are starting again, ladies and gentlemen. Good afternoon. Thank you for joining us. This is the SJMC Cardiology Webinar Series, 3rd April 2021. The topic of our discussion is to stent or not to stent. We have a stellar group of panelists helping us discuss when to intervene in coronary artery disease, an important topic. I'll introduce Dr. Jayamala, our chief, Dr. Choi, my colleague, Dr. Naveen, my colleague, Dr. Lau joining us from the comfort of his home, and we have Dr. Rosalie, who's sitting next to me, who needs very little introduction. Now, as per the format of our webinar series, we will be discussing cases that we have seen in our practice and discuss around it. Before I start presenting cases, I would like to cover 3 important points which will be relevant for our discussion today. This is stable versus unstable coronary artery disease, the location of coronary lesions that we are treating, which will determine the amount of myocardium at risk and therefore the prognosis, and the assessment of the significance of the coronary lesions we are treating. We will do this by assessing symptoms, hemodynamics, ECG changes, dynamic tests, and a measure called the fractional flow reserve, about which I'll say a few points soon. Now, a stable coronary plaque is characterized by a thick fibrous plaque. There's very little inflammatory cells. There's smooth muscle cells, a small lipid core which occupies less than 40% of the volume of the plaque. These plaques generally remain stable. They require generally no intervention and just intensive medical therapy, which will keep them stable. On the other hand, an unstable plaque has got a lot of inflammatory cells, very few smooth muscle cells, rather big lipid core, and these plaques are liable to rupture. And when they do, they result in acute formation of a thrombus which occludes the coronary artery, giving rise to acute coronary syndromes like acute myocardial infarction. In addition to intensive medical therapy, unstable plaques will require procedures like angioplasty to keep them stable. Now, for those of you who want to score 100 marks for Dr. Jayamala's questions, please pay attention to this next few slides. This man presented at 2 o'clock in the morning in March of 2004 with a hyperacute anterior myocardial infarction. He was immediately taken to the laboratory. An emergency angiogram was done. We showed complete occlusion of his proximal LAD. Emergency angioplasty was immediately and successfully done. 3 hours later, his RBs are preserved. This is his ECG 2 days later. There's some evolution. At this point in time, the echocardiogram showed some hypokinesis of the anterior wall, which he attributed to myocardial stunning. We were quite confident that the heart would recover given that everything was done quickly. And this is his ECG 1 year later, perfectly normal, as was the echocardiogram. An example of someone with acute coronary syndrome treated with intervention which probably saved his life. Now, on to location of coronary lesion. This is a tight proximal LAD lesion. This, in the old books, will be described as a widowmaker lesion, subsets a large area of myocardium, prognostically very important, and procedures like angioplasty would probably improve prognosis and save lives. On the other hand, this distal circumflex lesion subsets a very small area of myocardium, prognostically very unimportant. Intervention benefit the patient, but only the focus of the person in angioplasty and just requires intensive therapy. When we do fractional flow reserve, we pass a fine wire with a pressure transducer across the lesion into the coronary artery, and the pressure differential proximal to and distal to the lesion is measured. And studies show that if you have an FFR value of more than 0.8, it is quite safe to treat these patients with medical therapy. On the other hand, it's lower than 0.8, intervention will benefit and improve prognosis. This is the study from IRIS FFR registry published in Circulation 2017 and essentially involved more than 5,800 patients based on FFR measurement. They did not do intervention or angioplasty in 6,400 odd lesions in the study. The primary endpoint studies were cardiac death, myocardial infarction, repeat revascularization. Follow-up was for 2 years. Essentially, the results showed that the FFR value, the higher the risk of cardiac event. So, as mentioned earlier, FFR is low, intervention will benefit the patient. On the other hand, in this study, the measurement was more than 0.6, medical therapy would be reasonable. And therefore, this is again another important slide to score 100 marks in the MRS questions in patients with acute coronary syndrome and improve. On the other hand, if you've got stable coronary artery disease, optimal medical therapy would be prognostically safe, and there are several studies to show us this today. So how does intensive medical therapy improve prognosis? Using modern day imaging tools like optical coherence tomography, CT angiography, and intracoronary ultrasound, researchers have been able to show that you'll be able to do plaque stabilization, plaque regression by bringing the LDL cholesterol down, and currently one is to bring this down to 1.5 millimoles. Good control of diabetes, very important. Good control of blood pressure, important. Lifestyle measures for exercise and weight loss is also going to be important. And on to the first case. The first case I want to present is a 40-year-old Indian male presented with dyspnea exertion for 3 months. On the 19th of April, he was admitted with severe hypertension to another hospital. He denied any chest pain. The ECG just showed T-wave inversion at lateral leads. His creatinine was elevated at 300 admission. His echocardiogram was reported as normal, but he was diagnosed with acute coronary syndrome. The admitting physician felt that the heart was more important than the kidney, so emergency angiograms and PCI to the LVD was done. 5 days post-PCI, he developed nausea, anorexia. He denied any chest pain or breathlessness. By the 9th of May, his creatinine had gone up to 566. You see his list of medications, several drugs indicating that blood pressure control was difficult. On the 14th of May, came an opinion. He continued to complain of nausea and anorexia. Chest pain and breathlessness was not an issue. Clinical examination was essentially normal. He made a diagnosis of contrast nephropathy because of the angiogram and angioplasty. He felt that if he had any coronary artery disease, it was stable. He was referred to a nephrologist, admitted, rehydrated, symptomatically improved. The follow-up issues were mainly difficult blood pressure control. Chest pain and breathlessness were not an issue. And I'll show you coronary angiograms and will invite Dr. Lam to comment about the angiogram first. Dr. Lam, please.
Okay, thank you. The question all you can see the coronary angiogram. You will see that a quick look on the LED did shows a lesion of close to about 70 to 80% long diffuse lesion. At the same time, the diagonal branch has also got some amount of disease there. But the flow seemed to be very established. It was a TIMI3 flow. So with the TIMI3 flow, is it an ACS or is it an acute coronary syndrome? I think this needs to be highlighted and discussed more in detail.
Okay, Dr. Lam, as said, about 70%. Some of us felt that the lesion was far less than that in the proximal mid-segment, and most of the stenosis was in the distal segment, was a diffuse lesion. And so the questions to Dr. Lam, given the history that you have heard, Dr. Lam, do you think you would have rushed into an angiogram for this patient when he first presented?
No. I think basically when you have this group of a patient, first of all, there was no hurry to go and do an angiogram because the renal impairment is already there. You have no ECG criteria. I mean, T-wave inversion now is not a very strong criteria. And then moreover, your echo is again perfectly normal. With a good LV function, there was actually no rush in doing angiogram. This is what my say on this particular patient.
Thank you, Dr. Lam.
Yeah.
Dr. Naveen, do you think that angioplasty was necessary or beneficial in this patient, looking at the angiogram and the history that was given?
Thanks, Dr. Kanan, for the question. Well, I share Dr. Lam's sentiments. Looking at both the clinical presentation and also the angiogram, I would say that PTCA or angioplasty is probably not beneficial for this patient. The ECG changes were likely due to hypertensive changes. His echo was normal, good LV function. So intervention for the clinically or angiographically insignificant lesion would entail the unnecessary use of contrast, which will only worsen his kidney function. So inevitably, we'll be doing more harm than good for this patient. So in the end, we did see that happen. The patient's kidney function just worsened.
Thank you. Now, one more question to you. Do you think that this patient could have just been stabilized with medical treatment alone?
Yes, I believe so. During the index admission, we could have stabilized his blood pressure and kidney function, and the cardiac intervention could have been delayed. And it would have been best to actually include nephrologists in the decision making and the management for this patient. However, in this case, the angiogram was carried out, but the severity of the lesion also does not mandate intervention. And this patient could have just been managed with optimal medical therapy.
Great.
Thank you very much, Dr. Navin. We'll come back to this towards the end. We'll go to the next case. The second case is a 65-year-old Indian male who presented on the 10th of December 2020 with left-sided chest pain for 2 to 3 days. Each time would last a few minutes. Pain would occur at rest. He denied any chest pain on exertion. There was no history of diabetes or hypertension. Was a non-smoker. His mother had coronary artery disease in her mid-60s. The clinical examination did not reveal any abnormality. ECG on admission was shown to have SC segment depression, the inferior lead mild. A diagnosis of acute coronary syndrome was made, and his chest X-ray was suggestive of old TB, but otherwise normal. Troponin T was normal, as was the echocardiogram. The attending physician sent him straight away for CT angiograms, which showed deficits of calcium in his left main, in the left anterior descending artery, and the right coronary artery. They went on to perform CT angiograms, which is interpreted as showing a tight proximal LED and a LEGD1 lesion, mild disease in the distal circ, and moderate right coronary artery stenosis. Based on his presentation, the ECG and the CT findings, he went on for invasive angiograms. And invasive angiograms excluded significant disease in the proximal LED, but it confirmed that there was tight disease in the diagonal and distal circumflex, which was a small vessel. So they had discussions with the patient as to what should be done. And the patient said he would take medical therapy, he didn't want any intervention. Right, so we're going to show the angiograms, invite Dr. Jayamala to tell us about the angiogram. This is the right coronary artery, and the next one is the left coronary system.
Okay, I'm still waiting for the, all right. So first looking at the right coronary artery, it looks quite nice, some minor changes. So I won't get excited with the right. What about the left?
The left, not right. Left here. Okay. Okay.
Okay, so that is the left. As we can see right down there, there is a tight lesion. I think no one will argue that it is probably about 95, 90 or over. But it is the distal circ. Is there any other view?
No, these are two views we are showing.
Okay. Supposedly there's also a lesion in the diagonal, which I cannot see here.
We're not showing these lesions yet.
Okay, correct.
So in the interest of time, we'll just go on. Okay, patient elected for medical therapy. So these are drugs given, high-dose statins, Plavix. He was given a Bessa, which is diltiazem, because he couldn't tolerate a beta blocker. And during follow-up, subsequently he was discharged. He was essentially asymptomatic during follow-up, but he would complain of occasional atypical chest pains, mainly at rest. He had a treadmill done during follow-up, which is about 2 months later. We showed asymptomatic ST segment depression at the end of stage 2, 85% of maximum heart rate. So it means that no chest pain during the treadmill. So some of the issues are discussed will be this. Nowadays, some physicians appear to go straight to do CT angiograms in evaluation of patients who present with chest pain. The first question goes to Dr. Choi. Is there any more role for treadmill testing when evaluating patients who present with chest pain?
Thank you, Dr. Kannan, for the question. The short answer is yes. I think there's a role for treadmill testing in evaluating patients with chest pain, especially if the chest pain is rather atypical. I guess the first thing we need to do is to demonstrate ischemia, and if the baseline ECG permits it, we should always put the patient on the treadmill to look for ischemia. That would be my answer. I think there's a role in evaluating patient with chest pain.
Basically, we need to look for dynamic changes because CT angiogram is a very static picture, and sometimes we tend to overdiagnose. Right. The next question goes to Dr. Jayamala. Since this patient's treadmill was positive in February, even though he was asymptomatic, do you think that we should proceed to angioplasty in this patient? Will it make a difference for prognosis?
Okay, if we look at the angiogram, the lesions are very distal and they seem to supply only a small area of myocardium. I couldn't see the diagonal, but I was told it was also a very small and diseased diagonal. As such, I think I would stick to intensive medical therapy, like what you had said earlier, LDL right down, control sugars and blood pressure, etc. Coming back to the question you had asked earlier, is it wrong to go straight for a CT angio? Well, if you look at some of the guidelines, like the NICE guidelines, in patients who present with chest pain for the first time or diagnosed with unstable angina, that is being proposed as the first-line treatment for patients with chest pain. I mean, not
investigation.
Yes.
Okay. So having interest of time, we'll move on. But basically, we have to remember that things like CT angiography, first of all, tends to overdiagnose at times. And secondly, it's a static thing. It doesn't give us dynamic information. We still need to get dynamic information before we go on to treat the patient. We'll go on to the third case. This is a 40-year-old male lawyer, a lot of stress because of work, complained of recurrent discomfort in his chin and neck, both at rest and during effort for 4 days. On the morning that he came to the hospital, he developed chest pain while walking and again in the emergency room. This time the pain was severe with sweating, but once he came to the hospital, he became pain-free. He was found to be diabetic, he had labile blood pressure, he had a family history of coronary artery disease. Clinical examination revealed a heart rate of 90, blood pressure was 140 by 88, the rest of the clinical examination was normal. An ECG was done, essentially doesn't show anything very acute. So because the patient was pain-free, because the ECG looked quite calm, he was admitted to the coronary care unit, given low molecular weight heparin, a beta blocker, high-dose statin, antiplatelet therapy, and the plan was him to have angiogram the next day. These are his blood findings. Triglyceride is elevated. LDL certainly not satisfactory for someone with active coronary syndrome. We want to bring it down to 1.5, as Jaya pointed a moment ago. Glucose is elevated, and several enzymes did rise, both troponin T as well as CKMB, although not phenomenally high, was certainly abnormal. The echocardiogram was reported showing hypokinesia of the distal apical segment, indicating that the LAD territory was in trouble. These are the ECGs done on the day on admission, and then the next day we invite Dr. Choi to look at the ECGs and tell us whether he thinks he would be worried by the second ECG or was there any change.
Yeah. So as always, ECG excites me a lot. Thank you for the question, Dr. Kannan. When you compare these two different ECGs together, you can see that the subsequent ECG shows a subtle kind of T-wave inversion over the anterior leads that you can see. And I would suppose that this sometimes it points towards some kind of a Whelan syndrome, perhaps proximal LED stenosis. And with the dynamic changes that we see of these two ECGs, there has to be something going on for this patient.
Thank you, Dr. Choi. I put up the second ECG mainly for those of us who see patients like this, especially if the presentation is atypical. If the presentation is typical, I think most of us will have our guard up. But if the presentation is atypical and you miss this, you might send him home the next day. But these subtle changes tell you that something is going on and the patient needs to be observed and investigated further. So this is the angiogram done on the patient, and we invite Dr. Rosalie to comment about the angiogram for us.
Okay, this is the angiogram of the left coronary artery. The one that goes to the medial is a circumflex, and that looks quite clean. And the one that is on the top is the left anterior descending artery. And if you look at all the three blood vessels, the most important vessel is still the LAD. So what is obvious to me is that in the proximal segment, there is a mild stenosis in the proximal LED. So this is something that did not or does not appear significant.
So, Dr. Rosalie, the question to you is, if you had been the person doing the angiogram, what would you do? Would you go away and stent this vessel immediately?
No. I think it's very clear that with a mild disease, you should not stent it. It is also not uncommon to have lesions, with that has got plaque rupture, that has thrombosis, that later after a day you can actually clear it. So in this case, I will not stent this. I will assess this further and see whether this lesion is significant or otherwise.
Thank you, Dato'. The operator was in agreement with you, although this decision was made, I think, 1 or 2 years ago. The operator did an FFR measurement, and this was the reading 0.88, 0.87. Can you interpret this for us and tell us what you do?
All right. So when you give adenosine, it causes vasodilatation, and then you actually compare the flow distal to the stenosis as compared to the proximal to the stenosis, in this case, the guide. And what 0.88 means is that if you get maximum vasodilatation, it is 88% of what is normal. And I think Dr. Kanan actually showed us some data. If there's any level of measurement which is less than 0.8, and the paper they studied showed 0.75, it means to say that the stenosis is significant and therefore needs to be treated. So in this case, it is more than 0.8. I would not treat this other than just medical therapy.
Thank you, Dato'. So the patient was advised medical therapy. He remained asymptomatic, came for regular follow-up. At 1 year of follow-up, the patient requested that a CT angiogram be done, and a CT angiogram was done. And on the CT angiogram, the lesion was considered to be significant. And so because of that, invasive angiograms were advised. Before his angiogram, a treadmill test was done to assess for functional assessment to see whether there's any inducible ischemia of the effort. He walked to stage 4, no ischemia was done. Some people said that they would cancel the coronary angiogram based on the treadmill, but because of the CT angiogram findings and because of the location of the lesion earlier, angiography was done. I will show you the angiograms. This is on the day he first presented. This is 1 year later. That's what you want to comment?
Well, the lesion looks about the same 1 year down the line. And therefore, this is considered not significant. And the functional test by stress test was so negative. I would again leave it alone, and I'm very happy with the medical therapy that was given to the patient.
Thank you, Dato'. So I've got 2 questions for you to follow. A patient presents with acute coronary syndrome. is pain-free for 24 hours. Coronary angiogram reveals a lesion of borderline severity, as in this case. What is the role of stabilizing the plaque by implanting stents versus intensive medical therapy? What are the benefits or disadvantages of each approach, if you can tell us?
Well, firstly, with regards to the lesion itself, what is very important is to try to stabilize the lesion. In this case, the lesion is only mild, and therefore, treating with stenting is not the way to go. In the acute setting, when you put in the stent, and the stent is something foreign, therefore the risk of stent thrombosis will always be there. So you only treat it when it is indicated to treat it, and that would be a significant stenosis. So in this case, clearly we should refrain from stenting this patient and then stabilize this patient with medical therapy.
Thank you, Rosaline.
Yeah.
The next question to Dr. Jayamala. Do you think, based on all the studies we have available, especially the last couple of years, in patients like this with stable coronary artery disease, is medical therapy as good as intervention?
Okay, first of all, you're referring to patients with stable coronary artery disease, not with people suggestive of anything of acute coronary syndrome. In patients with stable coronary artery disease, are we talking about symptoms, or are we talking about cardiac events such as death, myocardial infarction, etc.? If you're talking of symptoms, then angioplasty may be superior to medical therapy. But if you're looking at hard endpoints, basically for myocardial prevention of myocardial infarction, cardiac death, etc., intensive medical therapy, which means keeping it less, LDL less than 1.5, for blood pressure under control, sugar well controlled, and of course there's a role. Always tell my patients, don't get stressed out. If somebody bangs into your car, say hi and carry on. Stress is bad for you. So all those are as effective as putting in a stent.
Thank you, Dr. Jayamala. We're going on to the last case. We're doing good time, so I think there'll be enough time for questions today. Okay, this patient was seen almost more than 17 years ago. On the 6th of August 2003, this 40-year-old man presented at 5 o'clock in the evening with sudden chest pain radiating his left upper limb, fingers, and together that he was sweating and feels giddy. He was in hospital within 1 hour. He had no past history of similar symptoms. There's no history of diabetes, no hypertension. He was a non-smoker. No family history. Blood pressure 100/80, pulse rate 74 per minute. Nothing else to find. He was admitted to a hospital without cardiology services, and general physicians looked after patients like this those days. So the physician admitted him to coronary care unit. His interpretation of the ECG was that inconclusive, and he typically repeated the ECG every hour and found no serial change. No.
Dr. Choi, can you comment on this ECG?
Not yet. Coming to it. Yeah. Coming to it. Dr. Jay, as usual, things faster than the rest of us.
I thought the ECG
we take a long time to get through medical school, but she flew through medical school. The audience will now know why. Okay, so let me go on. The patient was admitted to the coronary care unit. 7 hours later, the patient's blood pressure dropped. He had more chest pain. They did another ECG which showed no change. His echocardiogram was shown to be normal. Now, being the ordinary humble cardiologist, Dr. Navin, can you please interpret the ECG for our boss? What does give us your thoughts? Whether you would think that you would worry about this ECG, and remember that we are now 17 years, 18 years ahead of time of this ECG, where we have far more facilities as compared to working in a hospital which only had an ECG and echocardiogram, no catheterization facilities.
I mean, to be fair to the admitting physician, this is not one of those ECGs that just shouts the diagnosis at you. But I think the clue here is probably the reciprocal ST depression that you see in the lateral leads, one in AVL. That will tell you harder to actually look at the limb and the chest leads. As you can see in lead 3 and AVF, there's actually an ST elevation of 1 millimeter or at least one box. It is quite subtle, but it could get more apparent in the subsequent ECGs, but unfortunately we only have one ECG here. So going by this, by definition, this ECG is definitely suggestive of an inferior myocardial infarction and it appears to be acute.
If I can just add on.
Yeah, please.
What the other thing is interesting is that if you see the V5, V6, the R wave is actually smaller than the V4, so you got to be very careful. And the R wave in V2 is slightly taller than the S wave. So these are subtle changes that it makes you want to make sure that you are going to observe the patient, assess the patient closely.
So we would do serial ECGs where the changes may become more pronounced as time goes by.
So we have a whole panel of very experienced cardiologists interpreting this ECG. To be fair to the general physician, they did many ECGs and they watched the patient. Today, if this patient had been admitted to a hospital with the angiogram facilities, they probably would have gone on to do an angiogram straight away. So anyway, in that hospital, they couldn't do all that. So this is what happened to the patient while they were watching him TCU. He went into VF arrest. He was defibrillated, and after they shocked him, he became asymptomatic. The third troponin done finally showed some positivity. The CK the next morning went up to 1,300 plus, and then he was referred to a hospital for angiograms. I couldn't find the original angiograms because that's about 18 years ago, and this is what was found. Yes, obviously the right coronary artery was the culprit. So Navin, you're right, as are the other members of the panel, that the inferior territory was the one in trouble. But the right coronary artery was very well collateralized from the left coronary system. And the left coronary system, you find severe stenosis in the mid portion of the LAD, in the distal portion of the circumflex. So discussions were held with the patient, his family, and especially because he was young, we went on to do 3-vessel angioplasty successfully and managed to revascularize the patient. Now, fast forward, the patient has come for regular follow-up. His treatment was perindopril 4 milligrams, rosuvastatin 20, cardioprin. His LDL over the years could be kept between 1.5 to 1.8 millimoles easily. In his last terminal in September 2020, that is 17 years after the acute event. And you can see that there's no residual ischemia. So my questions are first to Dr. Choi. Dr. Choi, is it known for initial ECGs in patients presenting with acute infarction to be normal? Although in this case, we said that ECG showed subtle changes. Could you have somebody with an infarct coming to you with a normal ECG, a normal looking ECG?
Yes, I think again the short answer is yes. It is not uncommon if you actually perform an ECG to a patient who has AMI too early. ECG will appear to be normal, but however, I guess the term normality is very independently defined. If you look hard enough, I believe sometimes you, like what Dr. Navin mentioned, you may be able to fish out a couple of subtle changes. The commonest will be hyperacute T waves. So before the ST segment gets elevated, the T wave will start to peak a little bit higher than usual. At that point, I guess you might want to have a look at the R wave. Usually the R wave will start to shorten before into Q wave. And importantly, we have to look at, in my opinion, I think the more important leads will actually be the reciprocal leads. Searching for ST elevation may be very difficult when the patient comes in a bit too early. But commonly, the ST depression, or should I say the flattening of the T wave, might appear a bit earlier than ST elevation. So these are the few things that we have to look. Keeping in mind that the heart is actually 3-dimensional. So we don't always look at, we want to see beyond it, see behind the heart, the back of the heart. So that's where the reciprocal leads are there. So I think the answer is yes, it can be quite normal looking, but I think we have to look really, really hard, especially when it's normal looking as well.
But the most important thing is still the history. If the history is very suggestive, keep looking, not just let the ECG guide you. Okay, Dr. Navin, why do you think is the explanation for the first and secend troponin T test to be negative?
Okay, as you mentioned just now, Dr. Kannan, the first and second samples were taken within 6 hours of the onset of symptoms. And we know for a fact that after a heart attack, it takes about 6 hours for the damaged heart muscle to release troponin into the bloodstream. So hence why the first two samples were probably negative. And we have the third troponin, which was done at the 7th hour. Therefore, that was weakly positive. But having said that, sometimes when we have large amounts of myocardium damage during a heart attack, we may see elevation as early as 4 hours. And this was 18 years ago. Yeah. So nowadays we have highly sensitive troponin T, which is actually able to detect smaller areas of myocardial injury and reduces the time to diagnosis. So that's something very helpful that we use in our emergency centers nowadays.
Thank you, Navin. I mean, two things, of course, this reminds us about the window period, still goes back to the history guides us. And secondly, of course, technology has moved along and we have got more sensitive tests which come up more positive earlier these days. One more question to you, Navin. Assuming that the interpretation of the echocardiogram was accurate, do you think there's an explanation as to why there was no regional wall motion abnormalities in this man?
I mean, Dr. Kannan, looking at your beautiful drawing of the coronaries earlier, it appears that he has a very well established collateral system. So that's probably the reason the echo was actually normal. But maybe we can get Dr. Lam to comment on this.
Are you still there, Dr. Lam?
Actually, if you look at the echo is actually highly specific, but it's not sensitive. So if your echo is normal, probably at that particular time the flow was still established. But it's not a sensitive marker to look for normal wall motion, especially when your trop T is negative. But today is a different story. If your trop T is positive and you get abnormal wall motion, you are very clear you have a heart disease. But if your echo is normal and your trop T is negative, it is absolutely not much of an issue. You're probably dealing with a normal patient. My best bet was there are subtle changes in the echo at that particular time. Machine technology are not that great. 20 years down the road, the machine of the echo now is a very, very sensitive marker with the interpretation of the clinical data.
Thank you, Dr. Lam. Now, this man remained stable for 17 years after near-fatal myocardial infarction. What could the reasons be for his stability, Dr. Navin?
Probably a few reasons for this. Firstly, he was treated by Dr. Kannan, who did an excellent job. Right?
Buy your lunch.
And continues to do so 17 years later in the sense that he ensures his risk factors are well controlled. Secondly, this could be also because of the fact that the patient is non-diabetic. He's normotensive and a non-smoker, so his risks are actually much lower. So we do have scoring systems, and if you actually score for a secondary cardiovascular event for this patient in view of his risk factors, I would say that his risk of developing a secondary event in the next 20 years is actually less than about 10%.
Thank you, Navin. Now, I think Dr. Jamala has actually answered this question, but we'll get Dr. Choi to reinforce. It was very important, especially for the frontliners, the general practitioners who are watching this session. Good medical therapy is mandatory in ensuring stability in coronary artery disease. That's the frontline thing. So what is good medical therapy, Dr. Choi?
Well, in my opinion, I guess good medical therapy is something beyond balloons and stents. So you'll start with the lifestyle change. For example, if the patient is smoking, we need to talk about smoking cessation, excessive alcohol, sleeping issues, and sleep apnea. We also need to talk about weight management. The patients who have metabolic syndrome, where being overweight is a factor in developing coronary artery disease. Compliance to medication is also equally important. Antiplatelet, especially if the patient suffers from ATS, with or without the angioplasty done. Statins, like what Dr. Kannan and Dr. Jia mentioned, how low can you go? I mean, 1.3, 1.4. These are all very important. If the patient still has symptoms, despite all these things, we can also talk about improving the anti-angina drugs. I mean, if you look down the list, there are so many ranging from beta blockers, calcium channel blockers, Vasral, and etc. My additional thing will be, of course, the patient has very poor heart function. I'm always very keen to talk about anti-arrhythmic drugs. How do you prevent arrhythmias in patients who have a tendency to develop arrhythmia? And that, I think, is what we call good medical therapy.
Thank you, Dr. Choi. So we are reaching the end of this session. Just some take-home messages before we go on to address your questions. So to summarize, a good history and clinical evaluation is still mandatory and vital in the management of coronary artery disease, especially to avoid unnecessary procedures and intervention. And the first case that we presented really highlighted this, that the diagnosis was missed and unnecessary procedure was done, the patient was put through unnecessary morbidity. Second point to make is advances in technology. Coronary CT certainly helped us better risk stratify our patients. We are making more diagnoses which would have missed in the past, and we improve morbidity and mortality as a result. But we must emphasize that this investigation must be done judiciously, carried out sensibly, and with limitations and interpretations honestly acknowledged. They don't want to over-diagnose and over-investigate and unnecessarily implant devices to patients. And finally, in acute coronary syndromes, intensive medical therapy and early intervention is important and will improve morbidity and mortality. In stable coronary artery disease, intensive medical therapy should be instituted and early intervention may be deferred. Terima kasih. We can now address questions.
Before we take the questions from the audience, can maybe we sort of rush through the first few cases. So maybe Kannan, you can help to tell us what actually do you mean when you say acute coronary syndrome? What is the definition?
Okay, there are several ways. That's a lecture by itself. To put it in a nutshell, we talk about acute coronary syndrome, we start off with a history. Generally, it's accepted that if someone develops angina within about a month, this means that something new is happening in the coronary vessels. We would not be able to predict how the patient is going to perform. And this is acute coronary syndrome because the patient may go on to develop more important things like myocardial infarction and damage to myocardium. So if you have got new onset angina, especially if angina is progressively getting worse, if it occurs at rest, then that goes into the category of acute coronary syndrome as compared to someone who has had stable effort angina which has been going on for many months or even years. Then if you have got chest pain occurring at rest, that's another important point in the history to indicate the patient becoming unstable, and there's a point for acute coronary syndrome. Now, next to the history, we come on to clinical examination. During clinical examination, if there's any evidence of hemodynamic changes associated with the ischemia, like drop in blood pressure, arrhythmias, or evidence of heart failure, that's another point supporting acute coronary syndrome. That's the examination. Then we go on to investigations. And investigations, we start with the most simple investigation, which is an ECG. If your ECG shows, for example, ST segment depression, or even more worrying, if it shows ST segment elevation, which might be transient, that indicates that this is really very unstable plaque, and this patient requires early intervention, a point in favor of acute coronary syndrome. Next to ECG, we have blood investigations, like what Navin mentioned about troponin T, or maybe the old-fashioned CK and CKMB. If there is a rise in these parameters, that's a point indicating acute coronary syndrome. So basically, acute coronary syndrome means, as compared to stable coronary artery disease, the plaque is undergoing instability. If it is not taken care of, if it's not cooled off, you're going to end up with damage to myocardium.
Just one question to Dr. Rosli. What is the problem about putting a stent? Patients say you put a stent, it looks so beautiful. Why are you reluctant to put in a stent?
Yeah.
He's never reluctant.
No, no, no.
Love stents.
I am. In the case that was, I was commenting just now, the lesion was only mild. Obviously, you don't want to treat something which is only mild, and patient doesn't really need it. So the thing about putting in the stent is that, especially in the acute coronary syndrome setting, then the risk of stent thrombosis is much higher because the area is not really stable. So if it's indicated, yes, but you have to make sure that the sizing is appropriate and you deploy it very well so that the stents are stick against the wall very well, very well expanded, and therefore you will get less or rather low risk of some stent thrombosis, and at the same time, over a longer period of time, the risk of coming back or restenosis is going to be much lower.
Can I also like to add this? All the things that Dr. Rosalie mentioned, I agree. But every time we put in a stent in somebody's coronary arteries, it comes with a lot of responsibility. Because stents, however well deployed, over years, they behave differently in different individuals. There's something called neoepithelialization and neoatherosclerosis that can develop in stents, and stents have been shown to thrombose even 7 years, 8 years down the road. So if you don't need to put a stent into somebody's heart, we certainly don't want to. If the plaque can heal naturally and remain stable, that would be the perfect thing to do.
Yeah, if you don't mind, I just want to come back to the acute coronary syndrome. So really is a range, as what Dr. Kanan was saying, a range between unstable angina, and between is non-STEMI, and the last one is ST elevation MI. I still feel that this is a platform to remind people that with ST elevation MI, this is where angioplasty actually saves lives. So the most important thing is that really the time the patient has chest pain and when he gets treated with angioplasty, time is all is in essence. If you feel a person and you're confident that it's an ST elevation MI, please refer immediately to a center that can do angioplasty because that's really the gold standard of care. If you get angioplasty done early, the earlier the better. And this actually has been shown to save lives. So it's very important. And if you are in a place that you cannot give, or refer quickly for angioplasty, and you have the means of doing it, please think about lytic therapy.
One more point before we leave that. Thrombolytic therapy has been shown to be inferior to angioplasty in the treatment of acute myocardial infarction. Remember that, you want to score marks.
All right. Now there are some questions from the audience. Is Vostural an effective drug in the medical therapy of stable angina? Maybe Naveen, would you want to answer that?
I mean, that's part and parcel of one of the medications that we actually use for medical therapy of stable angina, and it's been shown to actually reduce the glucose consumption in the ischemic myocardial cells. So we do use it in that quite extensively. Very minimal side effects. Some patients are worried will it bring down their blood pressure, but it's not known to have side effects. It's very safe drug that has been around for 15 years and we still routinely use it.
Okay, there are quite a number of questions. I think the next question I'll ask Rosalie, will a patient who has had stenting of his venous graft done 8 years ago benefit from intravascular lithotripsy if he develops restenosis of the stent?
Okay, the intravascular lithotripsy balloon, which is a new device that has come to our shores, or shockwave balloon, utilizes ultrasonic waves, and this will then break up the calcium. So it is only utilized when there is severe calcification at the segment which we want to treat. That is just one alternative of treating it. We have got other ways of trying to break down the calcium, and this can be used with specialized balloons, high pressure balloons. We drill them with a rotablator or orbital atherectomy system. And the reason why we want to try to get rid as much as possible the calcium is to ensure that when we balloon it, and if we decide to put in a stent, then the stent is well expanded and opposed. Because if the results are not going to be very good, then the risk of coming back is higher.
And if a person puts in a stent, there's always a higher risk of stent thrombosis. So shockwave balloon is only one of the ways of doing it. Most times are not for SVG or venous grafts. We tend not to see very calcified lesion. We tend to see soft or fibrotic lesion.
Okay, maybe the next question I shall pass to Troy. What would you do if a patient with chest pain, inferior ST elevation, but the angiogram shows a small RCA, say less than 2 millimeters, it says even less than 1.5 millimeters?
So I guess if you have a patient who has inferior MI, what it means is that the PDA is involved. It doesn't necessarily mean that it's from the RCA. So in that kind of situation, a common situation is actually missing out the fused circumflex. So probably the physician want to go back to the left side and wire around. It could be an osteo-circumflex occlusion. That's why you're not seeing the circumflex. And who knows, the wire might just pop in and there you go. The PDA is over there.
Okay, so the point you want to make is basically maybe if it is if the lesion may not be the right, it may actually be in the circ. So we are looking at the right, we may miss the real culprit. That's all. But let's assume you see the circ and it is normal, the LED is normal, the RCA is okay, and if you just say it is a small PDA, would you do anything?
If the flow is good, I guess we have established a flow restoration. Probably if the patient does not have symptoms and ST has resolved, I would just go for intensive medical therapy from there on.
Kanan, any?
Nothing more to add. I mean, if it resolves, of course, it's easy, but if the ST is still elevated, then the question comes, what should we do? I think if the ST is elevated, I would attempt to open that vessel. Because once in a while we have seen vessels that look small. Once you open them, they grow much bigger. So long as there's ST segment elevation, it's a reasonable vessel to do, I would still go and intervene in the acute setting.
Okay, so there are two other questions. One is FFR done routinely during an angiogram or only if you're in doubt? Okay, I'll answer that. Only when we are in doubt. If it's very straightforward, we just carry on. Okay, there are some questions for Rosalie. Someone young with atypical symptoms, positive stress test, but normal EAS. Angio shows CTO, proximal LED, good collaterals. To open or not to open? Once you open, of course, you have to stent lah.
Okay, with the proximal LED, I'm going to be very more concerned because the area of myocardium is large, and as I mentioned just now, the LED is still the most important vessel. I would still consider to want to open it. Of course, there's various techniques and ways of opening it, but I'll give it my best shot of trying to open it.
Okay, so next question to Lam. Someone with mild angina, mild hypokinesia in stress echo and high workload, stage 4, is medical therapy adequate or you will angio first?
The cardiac risk of this type of patient is only less than 3% in a year. Basically, medical therapy is more than enough. You don't need to go in and intervene and do coronary angiogram because you're not going to have a great prognostic change as compared to those with optimal medical therapy. So stage 4, I think basically is medical therapy.
Can I play devil's advocate here? Do you think that you'll want to know the coronary anatomy before you say I will give medical therapy? Our colleague Dr. Nick Ishak had a very interesting case about 2 weeks ago which he showed around. Very little change on the treadmill, and he went on did an angiogram because the patient had some symptoms, and it showed a very proximal LED lesion, and this was a young patient and very tight lesion, 90 or 95% as I remember. So do you think that we should look at the coronary anatomy and make a decision?
I think basically if you're looking at stress, image stress per se, we all know today their results are not that is 100% assuring that there's no ischemia. Where the best when you do a stress echo, you have close to 75 to 80% a positive predictive value. But if my patient actually have a very good stress echo and still have a lot of chest pain, something must be going on. Something must be going on. But if your stress echo is normal and patient is totally asymptomatic, I don't think there's a role of doing a coronary angiogram to see what is actually happening. And this is where the fault lies in, is that too many angiogram were done unnecessary, even though your stress test or stress echo are perfectly normal. And out of 10 angiogram that you do, you probably get 0.5 of them showing significant lesion, but the rest are not. But then if it's significant lesion of 80%, what would you do? Would you just put the stent straight away, or would you actually do an FFR? These are the patients you put in FFR. You put an FFR, which is again very normal, then you know that it doesn't make much of a difference at all. Putting in a stent, which is, putting in a stent is a man-made disease. So I think I'll be very cautious about doing an angiogram and then decide on how to interpret my stress imaging towards the angiogram and treat them as how what the next level is.
Okay, there were, yes, you want to add something?
The CT angiogram was not done for the patient yet. In the patient you mentioned this, that the question to Lam, why don't you do an angiogram first before? Because nowadays I don't routinely do a CT, but a person with atypical chest pain, obviously with a stress echo negative, I'm going to be more likely to agree as what you did, which is not to do anything. But if a person has got high risk, and this is where we should calculate the risk, a person is diabetic, especially very high cholesterol, a smoker, family history, I'll be very, very hesitant. I would at least do a CT angiogram and at least be comforted by knowing the results.
Okay, we shall go on to the ECG first. There's a junior MO from Sabah. I would appreciate if you can elaborate on the R-wave changes to look out for early septal MI. There was also another question: if a patient has chest pain and if the first ECG is not diagnostic, when do you repeat it? Maybe I'll pass that question to Troy.
Okay, so let me try. I can totally understand where you're coming from. If you're an MO in a very district place, the last thing you want to do is actually to miss an MI, and you're all alone at night. So I'm sure we've all been there. I guess the most important thing is the onset of chest pain. If the patient had chest pain, significant chest pain, at least about 6 hours ago, there has to be some ECG changes, I feel. So your specific question is about the R wave. You have to understand that the R wave is actually a depolarization of the myocardium. If your myocardium is healthy, it has to be tall and normal looking. So the more diseased the myocardium is, for example, due to ischemia, injury, then the R wave will start to get shorter and shorter, which is natural because there's less depolarization until it's totally infarcted, and what you're seeing is just the myocardium behind the dead myocardium, which is actually a Q wave. So you remember this spectrum of the depolarization and dead tissue, you will be able to catch the subtle R wave shortening in the early ECG in MI. And of course, not to forget again the reciprocal changes and also the T wave inversion. Anyone else would like to add?
How often do you do the ECGs if you find the first is normal?
I guess if the onset is still very recent, for me, if the patient has ongoing chest pain, 1 hour is good enough. There has to be. I remember someone used to say, if the patient is having ongoing ischemia, the ECG never lies. It will scream at you, please help me.
Well, having said that, I don't think it's a fixed and fast rule. I've actually had patients. I had one lady who came in with ST depression, looked like a non-STEMI. She was quite stable. I was thinking, we can just get the angio done the next morning. But before sending up to the ward, I just asked the medical officer to repeat another ECG, and then you have ST elevation. So that completely changes your management.
Yeah. Sorry. Yeah, what's our guideline? What is nation guideline says about it? How often?
Guidelines say every 10 to 15 minutes if you're not sure. If you're not sure, repeat it every 10 to 15 minutes until you see the ST elevation. If there's no more pain, that's it. Now we have very little time left. I was told. Comments about chelation therapy? 0 comments, otherwise I'll be short. And how many cases does SJMC apply pressure? Thank God they have not. I shall have to pass back to Kelly to show the QR code, otherwise it will expire in 2 minutes. Kelly, over to you. Kelly?
Please scan the QR code. It's coming on now.
It is coming out, otherwise you won't get the point.
Take this opportunity to thank all the panelists, especially Dr. Rosalie and Dr. Lam for joining us this afternoon and making the discussions even more exciting. Thank you, everyone.
Thank you.
Thank you very much.
Thank you. Thank you very much for joining. You have another, this will be left on for about 5 minutes. So you can have 5 minutes to bring out your phone and scan it. Thank you very much, everybody.
I think you're doing my.
Are you doing mine?
Thanks a lot.
Thanks, Rosalie. Thanks for coming.
This person asking if you are present to PCI.
Because we call up. Yeah, hospitals.
Penang.